So we will move to the next session, management of the rectal polyp, and we'll call the first speaker, please.
Dr. Sofia Gourtsoyianni is a consultant in the Gourtsoyianni Hospital, and she's currently selected as associate professor in the University of Athens. She's very keen in GI pathology, and she also has a hereditary relationship with this system. So we are looking forward to hearing this.
Thank you very much, Mrs. Chairwoman. Ladies and gentlemen, good morning. It is a pleasure to be part of the 8th Colorectal Games. I would like to take this opportunity to thank Professor Xinos for his very kind invitation. And I will talk about the staging assessment on the management of the rectal polyp. So the adenocarcinoma sequence in colorectal cancer is a concept that is well known for quite a while now, and it is agreed that adenomatous polyps are precancerous lesions, and these should be identified and removed. And we can identify the rectal polyp as well as all the other colonic polyps present by performing a CT colonography. And according to the ESGE, which is the European Society of Gastrointestinal Endoscopy, and ESGAR, the European Society of Gastrointestinal and Abdominal Radiology guidelines, there are clinical indications for doing so that have been published, and it is widely accepted nowadays that CT colonography is performed instead of barium enema for the diagnosis of colonic polyps and cancer. CT colonography is performed in order to see beyond a colonic obstruction in patients who have a failed or incomplete colonoscopy, in patients who are frail and have comorbidities or contraindications for endoscopy, and also it is suggested for patients who are asymptomatic but are of average and high risk for colorectal cancer. In order to do so nowadays, we use a laxative-free technique. It is mandatory to give a fecal tagging regime, that is, the patient has to drink, digest orally a day before the exam oral barium or hyper or iso smaller iodine solution so that the feces in the colon gets tagged. We use colonic distension with carbon dioxide or room air. And the slice thickness of the images that we obtain are less than 3 millimeters, and the patient is scanned in prone and supine acquisition. There are different CTC software used by different vendors, and as radiologists we tend to look at the colon either on a 2D or a 3D image display or both, and there is also the possibility of the fly-through review. Now, the sensitivity for polyps that have a diameter that is greater than 1 centimeter with CTC is more than 90%. The protocols that we use have a very low radiation dose, and the significant target lesion that radiologists should be aiming to look for is a polyp that has a diameter higher than 6 millimeters. And even in the white paper that was published by the American College of Radiology back in 2009, it was stated that CTC can serve as an important adjunctive examination for colon cancer screening. Now, there are very few serious adverse events with CT colonography. The perforation rate is approximately around 0.04%. And this perforation rate, according to a very recent big national survey that was done in Japan, has been shown to decrease if we're performing staging and if we're performing screening with CTC. The risk for perforation is reduced if we use the automatic colon insufflator for the distension of the colon. Now, according to the SIGAR trial, which is a multi-center trial that was performed in the UK, and the results were published recently, up to 30% of the cases of the patients who have CT colonography, there will be a significant lesion that will demand that the patient has a subsequent colonoscopy. In addition, because with CTC we tend to identify less small and with adenomas, these do not get referred for a colonoscopy, and there is significance in the number of adenomas that get removed, and this is approximately 6% for the patients who have a CTC compared to 23%, which would have been the case for the patients who have endoscopy. Now, with the bowel cancer screening programs, which unfortunately we do not have in Greece, but there is one well established in the UK, there is an increase in the detection of polyp cancers and an increase in the identification of early rectal cancer. Also, in comparison with the improvement and the adequacy of minimally invasive interventions that are in place, such as polypectomy and local excision, there is a decrease in the morbidity and the mortality risk of resection surgery. And this is what has led the Pelican Cancer Foundation program have this initiative of providing workshops for multidisciplinary teams to identify and get more well acquainted with the significant polyp and early colorectal cancer. And this is an initiative in which Professor Brown is really involved in, and this have as an aim to stimulate the discussion and the training and to help people who are involved in MDTs to improve the outcomes by reducing the over-treatment of benign lesions and under-treatment of cancer. A significant polyp is defined as a large sessile polyp which is morphologically aberrant and where polypectomy may be unsafe or result in incomplete excision, while an early colorectal cancer is generally a small cancer of T1 or or T2 with a stage with a low risk for nodal involvement. Now, staging with MRI or endorectal ultrasound before a rectal significant polyp or early colorectal cancer is removed to assess depth of invasion and lymph node involvement is recommended, and the use of a consistent pro forma reporting on MRI and CT colonography in order to inform the MDT is required. According to the new guidelines that were published in 2017 by the Association of Coloproctology of Great Britain and Ireland, it is stated that it is important that the MDTs demonstrate appropriate expertise regarding these early rectal cancers in their clinical, radiological and histopathological assessment. And MRI should be performed prior to local excision of all rectal speck lesions, because 20 to 40% of speck lesions which initially have a benign histology subsequently are found to contain cancer within the lesion on complete lesion excision. Interpretation of an MRI examination that is performed immediately after the full thickness local excision is often hampered by surgical artifact and the presence of reactive lymph nodes. And pre-treatment MRI will also serve as a good baseline and is an important reference for comparison with follow-up imaging to enable early detection of luminal or lymph node recurrence. Now, how to perform an MRI examination and what kind of imaging to perform to stage these early rectal cancers. There are guidelines that have been published both by the Eureka Consensus Panel and from ESGAR. ESGAR published new guidelines in 2017, and both these guidelines say that while endorectal ultrasound is a perfect technique and the initial technique of choice for the differentiation and staging of T1 tumors, this allowing for accurate assessment of tumor ingrowth into the rectal wall, this examination has a limited field of view, is restricted for staging of advanced disease, cannot see distant lymph nodes. It is real-time imaging and does not provide an adequate roadmap for surgery and radiotherapy planning. It is also not adequate for stenosing kind of tumors and proximally located high rectosigmoid early cancers. MRI is the first choice for primary staging, and we perform MRI scans using phased array body coils. There is no need for endorectal coil. There is no need for a routine endorectal filling or enema, and there is no need for any bowel preparation prior to the examination. We use high-resolution 2D T2-weighted sequences and these are important to be obtained on a sagittal and on a true axial plane in order to assess the height of the tumor, in order to provide information regarding the T and the N states, to see whether there is any mesorectal fascia involvement, and to identify the presence of extramural venous invasion. Now, if we are encountering a low-lying rectal cancer, coronal to the T2-weighted high-resolution sequences are very important, and we have to pay special attention to the angulation. That is, we obtain the true axial images on a plane that is perpendicular to the tumor axis. And images like this are performed, and these help us to identify, especially for middle rectal cancers, the relation and the distance of the primary tumor to the mesorectal fascia. And if we have a low-lying rectal cancer, the coronal plane images should be obtained on a plane that is parallel to the tumor axis. Diffusion-weighted imaging is not considered according to the guidelines obligatory for primary staging. However, diffusion is an additional sequence that does not require the administration of IV contrast, and it's very helpful to identify very tiny polyps, which are very difficult to identify on the T2-weighted images, especially since polyps tend to have restricted diffusion, the same as rectal adenocarcinoma, and we see this is a large tubovilus adenomatous polyp that shows restricted diffusion due to hypercellularity of the polyp. In our MRI protocol, there's no need for paramagnetic substance administration or 3D T2-weighted or fat-suppressed sequences, and the examination time does not exceed 25 minutes. And with this, I want to thank you very much for your attention.
So thanks for your talk. Is there any question from the floor? Okay, so I have one question. May you talk to us about accuracy for MRI for rectal venous adenoma, because it's really difficult. Sometimes as surgeon, we receive patients in the clinics with big lesion. In fact, it's just adenoma, venous adenoma, and if you hear the radiologist, is very often T2 with node involvement, so I know that we don't have to talk about nodes, but this is the report very often of in our daily practice. So what can you say about the accuracy of MRI for this type of lesion?
So I can tell you there are no studies about the accuracy, the reported accuracy on polyps that do not have cancer, but I can tell you the accuracy of the radiologist, and it's not very good. It's very difficult for us. That's why we, before we do an MRI scan, we need to have a biopsy-proven cancer in order to stage it accurately. If we know, it is important for the radiologist to know that this was a polyp that was seen and not removed on endoscopy, so that we don't we tend to stage patients with precancerous lesions, because I think this lies to the difficulty in identifying the early breach of the rectal wall. But with there is a learning curve for radiologists, but we don't get to see a lot of, we don't get asked to stage that many polyps.
Okay, Professor Panis, and next Professor Gina Brown, if you want to add something in that sense.
I think I fully agree with Quentin. For us, when we have a venous adenoma, even if the biopsy say adenocarcinoma, it looks like a venous adenoma, the first choice is ultrasound, it's never MRI. And we perform a comparative study in 40 patients, and with MRI, you overstage the patient in 60% of the cases. And in our series of 40 patients, we have some T2 or T3, and at the end, we have only 3 patients out of 40 with T2, T3. So it means that if you do only MRI, you will discuss even neoadjuvant treatment for a benign lesion or a T1 lesion. So I think I will show it in my presentation. So for us, MRI is very important for the location of the lesion to see if we can do a local excision. But For the staging of a T0 or T1, I think it's a very bad exam. Sorry, Gina. But I think that the best exam is to do ultrasound.
The only problem is when these are very large and there is rectal bleeding, sometimes ultrasound is not, again...
Yes, but the problem is that if you have a patient with a T1 lesion and you say you give radioadjuvant chemotherapy and at the end you have a TME for a T1, I think it's a big problem.
But
why not?
Yes.
Can I say something? So we published in the colorectal disease this year, or maybe last year actually, and also in gut, the performance of MRI in this particular scenario. And actually our accuracy was 90%. Now, the reason why it was this good was that we turned the question around. So it's not about the T-staging anymore. It's about suitability for a preliminary local excision that can be done safely without compromise to the TME that could be done subsequently. So, in fact, because of what people are saying about MRI not being accurate, we're doing a randomized clinical trial where the control arm will be what you all think currently, which is that you shouldn't use MRI and that those patients should have EUS, and then if there's anything more than an advanced, anything more than T1, then the patient should have completion TME surgery. So that would be the standard of care. But in our investigational arm, these patients are going to have an MR-based strategy whereby if we see more than 1 millimeter of the muscularis propria intact, there will be a proposal to the patient that a local excision is performed, really for a combination of either diagnostic or therapeutic purpose. So you stage it on the pathology, but you know that when you're doing it as a procedure, that it is a safe procedure to do. In other words, the MR provides the roadmap, the entry point, the exit point, how much muscularis you need, how much beyond the muscularis you need to go, and where the next plane is. So that what we expect to find is that if we identify, say, 100 patients with 1 millimeter or more muscularis preserved, that nearly all early rectal cancers will be identified in this way. And by turning the question around, you're not asking is it T1 or T2, it's not relevant anymore. It's, is it safe to do a local excision, yes or no? And that's a different question to the T stage. So in that way, the question about benign versus malignant doesn't occur. It's, can you do the local excision? Do it, see what the pathology says, and make your plan accordingly.
Yes, but the local excision, the technique of local excision is not the same if it's a T1, a T2,
right.
or T3.
Okay, so the whole point is, in this trial, if we see 1 millimeter of submucosa preserved, then you just do, and it's not malignant, then you do a much less operation. But if you see that there is loss of the muscularis, but more than 1 millimeter preserved, then you have to do a proper TEM. But the point is, at the moment, these patients are not getting picked for the right procedure, even the right local excision plane, because nobody is giving that information. And EUS, unfortunately, does not give you that information, and that is why so many patients end up having a local excision with a deep margin involved that could have had a definitive local excision with a clear margin, and then could have been monitored. So that's the purpose of the trial, and we'll hopefully show you that we'll probably increase the rate of successful local excisions for early lesions by about 100%.
Okay, thanks for this discussion.